Hi, physiology students, and welcome to chapter 16, which is on the respiratory system. So your respiratory system includes ventilation, that's just breathing, the mechanical process that moves air into and out of the lungs, the gas exchange that we'll talk about between blood and lungs and blood and tissues, oxygen utilization by tissues to make ATP, this is called cellular respiration, and ventilation and gas exchange in the lungs, which is called external respiration. Oxygen utilization and gas exchange in tissues is called internal respiration. So gas exchange in your lungs occurs via diffusion. The oxygen concentration is higher in the lungs than in the blood. So oxygen will passively diffuse into your blood, and the carbon dioxide concentration in your blood is higher than in the lungs. So carbon dioxide will diffuse out of your blood into the lungs, and then you will exhale that as you breathe. So anatomically, we divide your respiratory system into the conduction zone, which gets air to the respiratory zone. And the respiratory zone is the site of gas exchange. The alveoli are the air sacs in the lungs where gas exchange occurs. There's 300 million of them. They provide a large surface area. The surface area is about the size of a tennis court to increase the diffusion rate. Each alveolus is one cell layer thick, and it forms a cluster at the end of the respiratory bronchiole. So this is a look at the relationship between the lung alveoli and the pulmonary capillaries. And you can see here's one alveolus and how there's different types of cells within it, as well as a macrophage. And you can see how a capillary filled with red blood cells will kind of surround the alveolus, and that's where the gas exchange will occur. Here's a micrograph look at the airspace within the alveolus, the different types of cells, and then another alveolus around it. And you can see here how the capillaries and then the type 1 and type 2 of alveoli cells will surround them. Another micrographs of alveoli, again, it's just fun to see kind of real microscopic looks at an alveoli. And you can see all the tiny little spaces here are all of the alveoli, the air-filled sacs of the lungs. You have two types of cells in the alveoli. Type 1 is about 95 to 97% total surface area where the gas exchange occurs. And type 2 secretes pulmonary surfactant and reabsorbs sodium and water, preventing fluid buildup, as well as this surfactant will help the alveoli from collapsing on themselves. So this is the pathway that air travels through the respiratory system, and you guys should know this pathway. It should be a review from anatomy, and I'll let you guys pause the slide if you need to review this pathway of air travel. Eventually, though, air goes from the conducting zone, which goal of the conducting zone is to get air eventually to the respiratory zone, and that's where your alveoli are. And the alveoli, again, capillaries will surround them and will be where carbon dioxide and oxygen gas exchange occurs. Here's the trachea and the respiratory bronchi. So you can kind of see here how the trachea divides into bronchi, primary bronchi, secondary bronchi, and tertiary bronchi to kind of create this tree-like structure. And at the end of each of the bronchioles will be the alveolar sacs. The functions of the conducting zone, basically, it wants to transport all the air to your lungs. The conducting zone will warm, humidify, filter, and cleans the air with the mucus, which will trap the small particles in the cilia that moves it away from the lungs. Voice production in the larynx as air passes over the vocal folds also happens in the conduction zone. And here's your larynx showing the vocal folds, the true vocal folds, and then the ventricular, the false vocal folds. And the glottis is just the space in between. More functions of the conducting zone, the mucus secreted by cells will trap small particles, and then that mucus will be moved along by the cilia, eventually to the pharynx, where it will be cleared by swallowing or coughing it up. In cystic fibrosis, the mucociliary escalator fails to function properly, and this is because abnormal mucus is too thick for the cilia to properly clear, and cigarette smoking damages the cilia completely and reduces the ability to clear all these harmful substances trapped by the mucus. So the thoracic cavity will contain your heart, your trachea, your esophagus, and thymus within the central mediastinum, and the lungs will fill up the rest of the thoracic cavity. The parietal pleura lines the thoracic wall, and the visceral pleura lines the lungs. And the parietal and visceral pleural are normally pushed together with a potential space between them called the intrapleural space. The diaphragm is a dome-shaped skeletal muscle of respiration that will separate the thoracic and abdominal cavities. This shows you a cross-section of the thoracic cavity, and you can see here where the heart is located. And then you can see here kind of how the lungs surround the heart with a parietal and visceral pericardium with this space in between. Here's a look at an X-ray of the lungs. So you can kind of see the lungs. You can slightly see the bronchial tree shown there. But again, they lie on either side of the heart within your rib cage. Physical aspects of ventilation. So this is just air moving from higher to lower pressure. The pressure differences between the two ends of the conducting zone occur due to changing lung volumes. And compliance, elasticity, and surface tension are important physical properties of your lungs. You have different types of pressure. Atmospheric pressure is the pressure of the air outside the body. And intrapulmonary or intraalveolar pressure is the pressure in the lungs. The intrapleural pressure is the pressure within the intrapleural space, and that will contain a thin layer of fluid to help serve as a lubricant to reduce friction. Inspiration is just inhaling. This will happen when the intrapulmonary pressure is lower than the atmospheric pressure. And expiration or exhalation is when the intrapulmonary pressure is greater than the atmospheric pressure. So this just shows you the peak values of the pressure differences. I won't have you guys know these values for that. The intrapleural pressure will be lower than both the intrapulmonary and atmospheric pressure. The difference between the two is called the transpulmonary pressure. And this just keeps the lungs against the thoracic wall and allows your lungs to expand during inspiration. Boyle's law talks about that the pressure of a gas is inversely proportional to its volume. So this means an increase in lung volume during inspiration as the lungs fill up with air will decrease the intrapulmonary pressure to subatmospheric levels. So this will kind of suck air in as you breathe, and a decrease in lung volume during expiration. So as you expire, exhale air out, the lungs will decrease in volume. This increases intrapulmonary pressure above atmospheric levels, so this will force the air to go out. Lung compliance just talks about how lungs can expand when they are stretched, and this is defined as the change in lung volume per change in transpulmonary pressure. I won't ask you guys to know that specific equation, but you should know that it can be reduced by factors that produce a resistance to that distension or stretching, such as the infiltration of connective tissue proteins, like in pulmonary fibrosis. Elasticity is the ability of the lungs to return to their initial size after being stretched, so we also call this recoiling. The lungs have lots of elastin fibers. Because the lungs are stuck to the thoracic wall, they are always under elastic tension, and tension increases during inspiration and will be reduced by the elastic recoil during expiration. Surface tension resists distension, and it's exerted by fluid secreted on the alveoli. The fluid will be absorbed by the active transport of sodium and secreted by active transport of chloride. It will raise the pressure of the alveolar air as it acts to collapse the alveolus. And people with cystic fibrosis, for example, have a genetic defect that will cause an imbalance of fluid absorption and secretion. You don't have to know about the law of Laplace, so I'm going to skip over that for now. But it just describes kind of this idea of how the alveoli will increase and decrease in size. A pneumothorax then is a collapsing of the lungs. So as air enters the pleural space, the rising intrapleural pressure rises so that the pressure difference keeping the lung against the chest wall is eliminated. The lung could collapse due to its elastic recoil, and a spontaneous pneumothorax could occur without disease or trauma, just happening by air leaking from the lung due to a puncture. from a broken rib or to lung disorders such as chronic obstructive pulmonary disease, cystic fibrosis, or some sort of rupture of what we call a lung blister. An open chest wound can also allow air to enter the pleural space, producing a serious tension pneumothorax, and each lung is in a separate pleural compartment. So a pneumothorax usually only occurs or affects one lung. So this is a look at the pneumothorax, and you can kind of see slightly here how the lung is kind of decreased in size, but it's hard to see from this picture. Surfactant then is a surface active agent. It's secreted by type 2 alveolar cells. It consists of hydrophobic protein and phospholipids, and it will reduce surface tension between water molecules by reducing the number of hydrogen bonds between the water molecules. So basically, surfactant just prevents collapse of the alveolar cells and of the alveoli, and it will always allow a residual volume of air to remain in your lungs. So these are the type 2 alveolar cells producing that surfactant, which just helps to keep the alveoli from collapsing on itself. Respiratory distress syndrome occurs because the production of surfactant begins late in fetal life. So premature babies may be born with a high risk for alveolar collapse called respiratory distress syndrome, but we can treat them with a synthetic surfactant. A similar problem may occur in adults caused by septic shock, where there's a reduced lung compliance and reduced surfactant, which could cause acute respiratory distress syndrome that is not treatable with surfactant. So mechanisms of breathing, we'll talk a little bit about. Breathing is called pulmonary ventilation. Inspiration and expiration are breathing in and breathing out. And this is accomplished by the changing thoracic cavity and lung volume. The thorax must be rigid enough for protection, but yet still flexible enough to act as a bellow for breathing. So this just shows expiration. You can see kind of the change in the lung size versus in inspiration, the lung size is greatly increased as air goes into the lungs. The diaphragm is the most important muscle in breathing. It will contract in inspiration, so it'll lower, making the thoracic cavity larger, and it will relax in expiration, so it will raise, making the thoracic cavity smaller. And then we have external intercostal muscles, internal intercostal muscles, and parasternal intercostal muscles, which will both have an effect on the rib cage, whether it's during inspiration or expiration. More muscles involved, either with breathing. There's quiet expiration, which occurs with the relaxation of the inspiratory muscles. This is a passive process. And abdominal muscles can also be used for forced expiration or forced exhaling. So again, there's lots of muscles that surround the thorax, and you can see them all listed here, and they each have a specific function, and whether they help with muscles of inspiration, you should know these. On the left are the muscles that help with inspiration, and the muscles on the right help with help with exhaling or expiration. So this takes you through the mechanisms of breathing, inspiration and expiration. I'm just going to read you the summary of this. So in inspiration, the thoracic and lung volume increases, causing intrapulmonary pressure to decrease, allowing the air to be sucked in. During expiration, the thoracic and lung volume decreases, causing the intrapulmonary pressure to increase, which forces the air out. So this looks at inspiration and expiration in a good table that explains the two and the mechanisms involved. And this takes you through a diagram of what happens with your diaphragm at rest, during inspiration, and during expiration. Spirometry is when the subject breathes into and out of a device that records the volume and frequency of air movement on a spirogram. You guys had a lab on this, and we'll briefly talk about it because we did kind of cover it in lab a little bit already. This will measure the lung volume and capacity, and it's really important for diagnosing restrictive and disruptive lung disorders. So here are lung volume measurements. I want you to know what tidal volume means, what expiratory reserve volume means, what inspiratory reserve volume means, and what residual volume means. vital capacity, total lung capacity, and inspiratory capacity, as well as functional residual capacity. So spend a couple moments just reviewing these slides from that lab that we went through. There's a relationship between lung volume and capacity. So the vital capacity can be calculated by adding up these three items together. And the same thing with the functional residual capacity. The total minute volume is the tidal volume times the breaths per minute. And this is about 6 liters per minute. That's going into and out of your lungs during a minute of normal breathing. So this is what a spirogram looks like. So this is tidal volume, normal breathing. Here's expiratory reserve volume. There's an amount of air that you can get out if you forcibly exhale. And the inspiratory reserve volume, if you inspire or inhale, you can get this much air in. And vital capacity is adding all of those together. Residual volume is just the amount of lung volume that stays in the lungs at all times, and you get total lung capacity by adding them all up together. So this is a great ventilation terminology table describing the term and the definition. So again, I would encourage you to take a look at this, review it from lab, but there will be several questions probably on your test about this. Some of the restrictive and obstructive disorders. So a restrictive disorder is when lung tissue is damaged, so the vital capacity will be reduced, but forced expiration is normal. And 2 examples of this are pulmonary fibrosis and emphysema. Obstructive disorders is when the lung tissue is normal and the vital capacity is normal, but forced expiration is reduced. And an example of this is asthma. People with pulmonary disorders frequently complain of dyspnea, which is a subjective feeling of shortness of breath. And this is a look how an obstructive lung disorder can be diagnosed by doing a forced expiratory volume test. And you can see just how with the obstructive lung disorder, the amount of the forced expiratory reserve volume would be greatly decreased. Asthma symptoms are shortness of breath and wheezing, can be caused by inflammation, mucus secretion, and constriction of the bronchioles. It's also called airway hyperresponsiveness. It can be allergic asthma, which is triggered by allergens, which just stimulate your T lymphocytes to secrete cytokines and recruit eosinophils and mast cells, which contribute to inflammation. Emphysema is the destruction of alveoli. This will reduce the surface area for gas exchange. So with fewer alveoli to put pressure on the bronchioles, they will collapse during expiration. Smoking is the most common cause, and it triggers inflammation and destruction of the alveoli by the immune cells. And this is just a look at how emphysema destroys lung tissue in normal lung and someone with emphysema. A chronic obstructive pulmonary disorder is any chronic inflammation, narrowing of the airways, and alveolar destruction. It could include emphysema, chronic obstructive bronchitis, and you can see here excessive mucus production and inflammation could be triggered by smoking. Most people with COPD smoke. Smoking also promotes the infiltration of obstructing fibrous tissue and muscle in the airways and remodeling of the blood vessels in the lungs, which can lead to pulmonary hypertension. It could eventually lead to hypertrophy and failure of the right ventricle. There's no cure, and is the 5th leading cause of death. It's estimated to move to the 3rd by 2020. Pulmonary fibrosis then, some people will accumulate fibrous tissues in the lungs when the alveoli are damaged. It may be due to inhalation of small particles. An example is black lung in minors. So gas exchange in the lungs. So we measure pressure. The atmospheric pressure can be measured using a barometer. And at sea level, the atmospheric pressure is about 760 millimeters of mercury, or also known as 1 atmosphere. So this is a look at within a vacuum. The measurement of atmospheric pressure, again, is about 760 millimeters of mercury. Dalton's law explains how the total pressure of a gas mixture is equal to the sum of the pressures of each gas in it. I'm going to skip over some of the Dalton's law calculations because I won't ask you guys to calculate partial pressures. But the result of gas exchange is basically in your alveoli, the percentage of oxygen decreases, carbon dioxide increases, which will change the partial pressures of each, which just allows your oxygen and carbon dioxide to diffuse naturally either into the capillaries or back into the lungs. So alveoli and blood capillaries quickly will reach equilibrium, and this will help maximize the amount of gas dissolved in fluid. Again, I'm going to skip over some of these physics laws, but again, what they're basically saying here is the relationship between the alveoli and capillaries. The capillaries surround the alveoli, which give just an incredible amount and an incredible way for gas exchange to occur quickly and passively between the air moving from oxygen moving from the air into the pulmonary capillaries and carbon dioxide moving from the pulmonary capillaries into the air to be exhaled. The significance of blood PO2, so the partial pressures of oxygen and partial pressures of carbon dioxide, basically these measurements, so measuring both will provide a good measurement of lung function. So the measurements will tell you how saturated oxyhemoglobin is. So it's just a good way to measure lung function by measuring these two partial pressures of both. And that's about all I'll ask you about that. Here shows the partial pressure of gas in the blood. Again, I won't ask you too many questions about this, but again, you'll notice that partial pressures of carbon dioxide will be higher in deoxygenated blood, and partial pressures of oxygen will be higher in arteries or oxygenated blood. Disorders caused by high partial pressure of gases, you get a problem with a sea diver, where the oxygen toxicity, 100% oxygen is dangerous at 2.5 atmospheres due to oxidation of the enzymes. So this could cause decompression sickness. So when a diver comes to the surface too fast, nitrogen bubbles could form in the blood and block small vessels. And it could also happen if an airplane suddenly loses its pressure as well. Hyperbaric oxygen therapy is when patients breathe 100% oxygen at 2 to 3 atmospheres pressure. It does not increase the amount of oxygen carried by hemoglobin when breathing sea level air, but it does significantly increase the oxygen carried by plasma. This is useful in the treatment of decompression sickness, gas gangrene, carbon monoxide poisoning, other severe traumatic injuries like crush injuries, and certain inflammations and diabetic sores. So some more regulations of breathing, which we'll go through just briefly. So basically, the contraction and relaxation of breathing muscles is controlled by motor neurons from 2 areas of the brain. It'll be voluntarily controlled by the cerebral cortex or involuntarily controlled by the respiratory control center of the medulla oblongata and the pons. So this just takes you through how chemoreceptors in the aortic bodies and in the medulla oblongata will basically just keep the breathing involuntary. So you don't tell your lungs when to breathe. This happens naturally. When you're sleeping, you don't tell your lungs to breathe. So this is involuntary control. And I'm kind of going to skip over this for now. Something else about breathing is that when ventilation is inadequate, your carbon dioxide levels will rise. So carbon dioxide normally will break down into hydrogen ions in the blood. And if you have too much carbon dioxide held within your lungs, your blood will become more acidic and your pH levels will fall. So in hyperventilation, carbon dioxide levels will fall and pH levels will rise as the opposite effect. So when ventilation is inadequate, carbon dioxide levels rise and pH levels fall. It becomes acidic in your blood. And in hyperventilation, carbon dioxide levels fall because you're hyperventilating, you're decreasing the carbon dioxide too quickly, and pH levels will rise. Oxygen levels do not change as rapidly because of oxygen reserves. So oxygen levels are not a good index of the control of breathing. Ventilation is controlled to maintain constant levels of CO2 in the blood and oxygen levels will naturally follow. So here's a look at the effects of pH and the partial pressures of carbon dioxide on ventilation. So this is normal ventilation, has a pH. This doesn't show pH, so I'm going to skip over this one for now, but this shows total minute volume. In hypoventilation, you're not breathing as much. Normal ventilation, hyperventilation, you're breathing a lot more because you're hyperventilating. When increased carbon dioxide in the fluids of the brain decrease the pH, this will be sensed by the medulla, and ventilation will be increased to try to counteract that process. Other than that, I'm going to skip over some of the chemoreceptors in the medulla, and I want to finish up with sudden infant death syndrome and a couple other ones here. Let's just see where we're at. This is a longer PowerPoint and a little bit of hemoglobin and oxygen transport, which we went over in blood a little bit. So a sudden infant death syndrome, it's a sudden death of an infant under one that cannot be really explained. It's also known as crib death. The evidence suggests it may be due to a failure of the central or peripheral chemoreceptors to detect a rise in carbon dioxide. It remains the leading cause of death in infants younger than 1 year. Obstructive sleep apnea is a condition in which there are 15 or more periods of apnea during sleep caused by a temporary blockage of the upper airway. Dangers include pulmonary hypertension that could result in the right ventricular hypertrophy. So people with obstructive sleep apnea must wear some sort of gear or a device when they sleep to keep their oropharynx air passage open. So hemoglobin and oxygen transport, the plasma oxygen concentration in systemic arteries is about 0.3 milliliters per 100 milliliters of blood, and the total oxygen content of blood will depend on the partial pressure of oxygen and the hemoglobin concentration. So this just kind of shows how plasma and the partial pressures of oxygen and how oxyhemoglobin will be more saturated with oxygen in whole blood rather than in plasma. So your oxygen is more being traveled or taken up in the hemoglobin in your red blood cells. So most of your oxygen is bound to hemoglobin, which consists of those 4 polypeptide globin chains. Each hemoglobin can carry about 4 molecules of oxygen. So there's about 200 million hemoglobin per red blood cell. So each red blood cell can carry over 1 billion oxygen molecules. This is a look at the structure, the 4-chain structure of hemoglobin, and how at the center of each hemoglobin chain is a heme group, which will carry 1 oxygen. There's different forms of hemoglobin, oxyhemoglobin or reduced hemoglobin. There's methemoglobin and carboxyhemoglobin, where hemoglobin will be bound to carbon monoxide, and it has a much stronger bond with carbon monoxide than with oxygen. This is why carbon monoxide poisoning is so dangerous, because carbon monoxide has a much higher affinity to be bound with hemoglobin, so it will take up the oxygen spaces. Percentage oxyhemoglobin saturation is measured to assess how well the lungs have oxygenated the blood, and the normal is about 97%. And you can measure this with a pulse oximeter or blood gas machine. Hemoglobin concentration, oxygen carrying capacity of blood is measured by its hemoglobin concentration. Anemia is below normal hemoglobin levels, and polycythemia is above normal hemoglobin levels. Erythropoietin is made in your kidneys. It's a hormone that will stimulate hemoglobin and red blood cell production in the red bone marrow when oxygen levels are low. This gives you the loading and unloading of hemoglobin to oxygen as it binds oxygen in the lungs and then drops off oxygen in the tissues. Oxygen is unloaded at the tissues, and it will transfer into the tissues passively because of the partial pressures of the two. Oxygen remaining in veins serves as an oxygen reserve. And this just shows you the oxygen dissociation curve, which shows you how well oxygen can dissociate from hemoglobin at different partial pressures of oxygen throughout the body, whether it's veins at rest. So at veins, the percent of your oxyhemoglobin is about little less than 80% saturated. but in your arteries, it's about 100% saturated. And that makes sense because your arteries carry the oxygen from the lungs to the rest of the body. And the amount of oxygen unloaded to the tissues is just the difference between these two, whether it's an artery or a vein. pH and temperature change will affect the affinity of hemoglobin for oxygen, and this will ensure that muscles get more oxygen when exercising. So the affinity will decrease at lower pH and increases at higher pH. So this just says that more unloading of oxygen from hemoglobin occurs at a lower pH or a more acidic. So oxygen will be more unloaded or dissociated with hemoglobin at lower pHs, and this will always shift the oxygen dissociation curve to the right. So if we shift the dissociation curve to the right, that means that oxygen is being offloaded from hemoglobin more readily. And higher pHs, so more basic pHs, will shift the hemoglobin dissociation curve to the left. And that means that the hemoglobin holds on or grabs tight of oxygen more readily. The hemoglobin affinity for oxygen is decreased at increased temperatures. So this means this is a good thing as you're exercising and your body increases in temperatures. It enhances the amount of oxygen that can be unloaded to the tissues. And this will shift the curve to the right. Carbon monoxide poisoning is so incredibly dangerous. It's suspected when the blood carboxyhemoglobin is greater than 10%. It's usually caused by the burning of fossil fuels by a faulty appliance or a vehicle within an enclosed space. Symptoms could include headache, weakness, dizziness, nausea, confusion, memory loss. People may be treated for carbon monoxide poisoning by breathing 100% oxygen, so that hyperbaric oxygen. I do want you to know the factors that affect the affinity of hemoglobin for oxygen, especially the pH and the temperature. So a decrease in pH will shift the curve to the right, an increase in temperature will shift the curve to the right as well. And this just means that oxygen will be more likely to be offloaded more easily from the hemoglobin. Some inherited hemoglobin defects. Sickle cell anemia is found in 8 to 11% of African Americans. The affected person has the hemoglobin S with a single amino acid difference. And it just has a deoxygenated hemoglobin S shape, which will polymerize into long fibers, creating a sickle-shaped red blood cell. And this just hinders the flexibility and the ability to pass through small vessels. Sickle cell anemia, more about it. Blood flow to organs will be restricted. Red blood cells will eventually hemolyse or split apart. It's treated with hydroxyurea, which will stimulate the production of fetal hemoglobin without the defect, and this defect will impart a high resistance to malaria. So many people with sickle cell anemia will be resistant to malaria. So here's a look at a normal red blood cell and a sickle cell red blood cell, flattened, not as capable of carrying oxygen in its hemoglobin. The carbon dioxide transport. Carbon dioxide is carried in the blood in 3 forms: in the plasma, attached to amino acid, or as bicarbonate ions. And the bicarbonate ions is the most important way that carbon dioxide is transported. I'm going to skip ahead. What I want you to know about how carbon dioxide is transported has to do kind of with the acid-base balance of the blood. So the acid-base balance of the blood is maintained, and we talk about it maintained in your respiratory system because it has to do with carbon dioxide and how it's transported. So the pH normal range of blood is from about 7.35 to 7.45. And since carbonic acid can be converted into a gas, carbon dioxide, and easily exhaled, it's considered a volatile acid, and it will be regulated by breathing. Non-volatile acids are buffered by bicarbonate, and they cannot be regulated by breathing, and they're regulated by the kidneys. So if bicarbonate acts as a buffer, and the ion is a weak base and the major buffer in the blood, the buffer just helps to maintain normal blood pH levels. Kidneys will help by releasing hydrogen ions in the urine and by producing more bicarbonate. So this just shows how carbon dioxide will be turned into this bicarbonate ion, and that's how it's transported in the blood, and it acts as a buffer. This is important when we talk about acidosis. So when your blood pH falls below 7.35, we can have respiratory or metabolic acidosis. Respiratory acidosis is caused by hypoventilation, where the rise of carbon dioxide levels increases the hydrogen ions, so it'll lower the pH levels. And metabolic acidosis is caused by excessive production of acids or loss of bicarbonate, such as the case in diarrhea. Alkalosis is when the blood pH rises above 7.45, and respiratory alkalosis is caused by hyperventilation. So they'll blow off excess CO2, so the hydrogen ions will decrease, raising the pH levels of the blood. And metabolic alkalosis is caused by inadequate production of acids or overproduction of bicarbonates caused from the loss of digestive acids from vomiting. Alkalosis, when blood pH raises above 7.45, a little bit more about the respiratory and metabolic alkalosis. We just read through that. I feel like this is the same slide. Let me just go back. Acidosis, alkalosis. Yeah, we just kind of read the same slide. So what I want you guys to know here are just kind of these 4 basic acid-base imbalances in the body, whether it's an acidosis or an alkalosis, and whether it's a respiratory or metabolic for either one. So there's 4 imbalances. I'm also going to upload a video of these 4 acid-base imbalances as a supplemental video to watch from a workshop that I do at another college. So take a look at that video as well. And I think we're going to end kind of with that, and I'm going to point you to that video to look at for a little more information. So this will end this chapter. Thanks for listening, guys.